Rebecca, I think we also have, is it your occupational therapist with us today as well? Is Allison with us?
Yes.
Okay, yeah. Well, I'll welcome Allison too. Then maybe we can chat with both of you guys and we can see what I can do to be helpful. So I'll welcome Allison as well.
Hi, nice to meet you.
Yeah, you as well. Rebecca and Allison, would you mind giving me a little bit of background about, who you guys are? How do you know each other, first of all? And maybe what I can do to be helpful.
Becca, do you want me to go ahead? Okay, so I'm Allison Carmichael. I'm a occupational therapist working mostly with neurological clients, mostly post-stroke, but I do also see traumatic brain injury patients and spinal cord injury patients, and also neurodegenerative patients as well. So MS, Parkinson's, all those as well. Becca and I know each other. You started seeing me in February, is that right, Becca? Into February? She had a stroke as a result of a amniotic fluid embolism during labor last year in May, and was seeing a colleague of mine in a different hospital system. And then her insurance changed over and she started seeing me after the beginning of the year.
Okay.
I believe we're reaching out today because your husband, Becca, is wanting to see if the Motus Nova would be a good solution for your tone. Is that right?
Yes.
Yeah. So she has, it's like a 1+ to a 3 on the modified Ashworth scale, if you're familiar with that. She's getting Botox injections. She's on baclofen. And they're needing some help at home with exercises and things like that, because we only see her here once a week. So doing some stuff at home would definitely be beneficial. And we're wondering if this device could possibly help with that. So how does it work for people who have high tone and spasticity?
Sure. Good questions. Yeah. And thanks for the background. And remind me just a little bit about maybe the rehab experience thus far. Inpatient rehab, outpatient rehab. I kind of know where you are right now about maybe what type of
so she had inpatient rehab right after, and it's the Methodist Le Bonheur system here in Memphis. That's where she went, and she had some outpatient. I think it was from, correct me if I'm wrong, Becca, July to December, and then your insurance changed and you came to see me in February for outpatient, right? Yeah, that's right.
Okay, gotcha. Okay. So, and you guys have been working together basically weekly since February, is that correct?
Yes, sir.
Okay, great. And Becca, tell me, what kind of things are you doing at the house too? Are you doing exercises at home?
Yes.
Okay. Okay. Yeah.
And she helps take care of her daughter as well, which is one of the things we've really been focusing on as OT progresses, because that was something that was really important to her, to be able to help bathe and change and care for her daughter.
Yeah, and that was one of the things I was going to ask is what are kind of the goals? It's always about what kind of things we're having trouble with now and what type of things are we looking to be able to do going forward. And so I'd ask maybe what are some of the main goals? And it sounds like you already, that's one of the main ones. Anything else? Anything
you want to add, Becca?
No.
Okay, so mainly just participating more in Anne-Marie's life as much as she can. Maybe doing some work eventually, going back to work. She's a registered dietitian.
Oh, great. Okay.
And just kind of participating more in life, being able to go on date nights with her husband, and just really being able to have a better quality of life.
Yeah, great. Okay, again,
and then also all those performance skills, she needs to be able to do all those things.
Yeah, and then all the peripherals, all of the extra things that many
walking
of us take for granted. Yep. That's
using both arms to be able to do tasks.
Yeah, exactly. And so Becca, what are you walking around your house right now? Are you using a cane, a walker? What are you?
No.
Okay, great. Okay.
Yes.
And how
she walks very well.
Excellent. Very good. And so I guess maybe what I can do now is give you guys a little background. I don't know how much you know about the Motus hand.
Not very much on my end. I'm not sure how much research y'all have done, Becca. I don't have very much information about it.
Sure. Well, let me give you
Mhm.
guys a quick backstory too, because I think it's helpful to understand kind of where it's come from. So
Okay.
the backstory here is, I guess the long and the short of it is, it's not a new idea. The various versions of this have been in place since about 2001, and they were originally sort of conceptualized as a response to constraint-induced movement therapy. So
Okay.
Edward Taub was one of those original scientists, and Steve Wolf were sort of the original scientists who were developing this approach that at present is sort of the best course of action to help people regain purposeful movement of their upper extremities following a neurologic injury. And that process involves the use of these really, really intense rehab programs where you have often with neurologic injuries, one side is not so, is the weaker side and one side the stronger side. What you do is you constrain, you put a mitten or you put a cast or you put a sling on your stronger side. And that encourages you, they often call it forced use originally before it was called constraint therapy, forces you to use your weaker side. And that causes you to gain a lot of movements, volitional movements during the day. And that's all well and good. And they demonstrated time and time again that it's one of the best things we can do in terms of how much it can help people. The problem is when you start to think about, well, how do we take this from a research approach to real clinical practice? And that challenge is basically there's not enough therapists out there in the world to do that. Just physically are not enough hours. And so the idea was, can we make a robotic device? Can we use some technology to help take some of those features that constraint therapy can do and deliver it in a more sort of efficient way where we can kind of amplify the hours that people would normally get. And so that's the sort of backstory. And what it is effectively is a robotic exoskeleton. It's a fancy word, but it's a sleeve that goes on your arm that helps to sense your movements. So it has a series of sensors, digital sensors and force sensors that can quantify how much you can move and also quantify how much forces are being applied. And those two things are important because the relationship between those two things is effectively tone. So we can quantify tone, we can quantify the rate change of tone or spasticity, for instance, and we can also quantify strength. These things are very, very important because these details help us make a virtual environment that you effectively play in. You play games, and those games require you to move, to engage in them. And so by nature of playing games and interacting with card games, space shooter games, these sort of things, you are doing a lot of repetitive task practice. Now, that's all well and good, but what's really important too is not just the fact that it can sense your movements, but it can help you as well. So in the robotic device, there's an actuator, that's a fancy word for a muscle, something that can move you, that can actually contract and relax. And as it contracts and relaxes, it can help an individual initiate their movements if they're having trouble starting movements, or it can help you amplify your movements if you're having trouble completing a range of motion activity. So those two things kind of work together where we can sense people's movements, detect when they're having trouble completing or initiating a movement, and we can provide some backup. It'd be very much like Allison kicking in there, being, having her hands try to help you complete a task if you're having trouble. Of course, it's not a perfect analog for the skilled therapist, but it's a way that we can get high doses of movements. And we know from the literature, we know from the science that to make reasonable changes in our brains, we need to get around 400 to 600 repetitions of movements per day. And that's a lot of rehab, that's a lot of movements. And it's very, very hard to get this in 1 hour of rehab that you have with Allison a week. And because it has to happen every single day. And so these tools can be deployed in your home, Becca, where you can engage and get these types of movements that are going to cause those positive changes. So that's kind of the fundamentals of it. But it also, the kind of third thing, if you imagine a stool, stools are very stable. We have to have a third leg here. The third leg is the biofeedback. And that biofeedback tells you the sort of consequences of your movement. And that's what you're learning from. Being able to have a stimuli that tells you, hey, you did it well, or you need to do it a little bit differently. Or, for instance, if there's a lot of tone, we can present you with biofeedback that helps you try to relax, for instance. And, if it's upper extremity tone, it's often in our flexion synergy pattern. We can help you kind of condition activation of your extensors and try to relax your flexors. So we can provide feedback based on those movements that we're trying to de-emphasize and encourage you to do motions that are what we want to emphasize. That's the sort of critical elements of biofeedback. And now we are very much of the mindset that we are trying to help people gain endogenous control, independent control of their limbs again. So it doesn't rely on stimulation, like an electrical stimulation, right? It's all kinematic based sensors. So there's no stimulators, there's no electric shocks that are happening through like a functional electrical stimulator device or an NES device. It's all kinematic based, so movement based. And we can do this because we have a lot of really high fidelity sensors that are there that can detect very, very small degrees of movements, fractions of a degree of movement. Very, very good. And so that's kind of it in a nutshell. But what's also very, very important is it's not a static thing. All of those characteristics I was talking about change over time. And those things change over time as you progress. So as you have increased range of motion, it will respond and help you, encourage you to move in larger ranges of motion. As you need less and less assistance, it will provide less and less assistance, right? Because it doesn't want to help you. The idea is you don't want to provide too much assistance because someone will become dependent on that. So you want to slowly take away that help as someone doesn't need it. And it can actually transition away from being helping you to a more resistive type of exercise to help you improve your strength. So it can kind of transition. It can flip back and forth based on your current state. Similarly, we're detecting those changes not only within a period of weeks or months, but those changes are happening on a second by second basis. So we can detect when fatigue is happening. Very, very common, right? If we have some fatigue even within a given session, right? Someone's movement capabilities may decrease because they're fatiguing. So we can detect that, and we can change the things like the FIT principle, all of our periodization approaches where we are like modifying the intensity and the rest intervals, for instance. So all those things are modifiable as well. And again, we developed this whole process originally in the clinic, went through a big multi-site randomized control trial in the clinic, and then we transitioned it all to the home environment. We had to test its safety and efficacy in the home, and that took a long time too. And this is one of the reasons why it takes about 15 or plus years to go through all of those scientific steps to make sure that we have the safety, the efficacy, and the ease of use before we can kind of get it out into the world. And so that's probably why you're only hearing about this now, because we spent the better part of 20 years making sure it did the thing we thought it did before we try to get it out to the world.
Yeah. Okay.
So that's kind of the nuts and bolts of this. I mean, I'm happy to go into any more details if you guys have questions.